Welcome to the Deep Dive, where we sift through the most critical information and pull out those essential insights, helping you truly grasp complex topics without getting bogged down. Today, we're plunging into a world where every single second is literally life or death, cardiac arrest. For this deep dive, we're drawing from the latest expert guidelines and care protocols for this really urgent medical emergency. Our mission is to illuminate the rapid, precise actions taken by healthcare teams from the very first moment cardiac arrest is recognized right through to post-resuscitation care. You'll walk away understanding the distinct heart rhythms, the life-saving interventions, and critically the why behind each crucial step. We're essentially looking over the shoulders of emergency physicians as they navigate this high-stakes scenario.
Indeed, and it is high stakes. Cardiac arrest is a clinical state defined by sudden unresponsiveness, the absence of a pulse, and little to no breathing effort. It demands an immediate, coordinated, and highly structured response. It's a scenario we as emergency physicians encounter often, and those immediate actions truly dictate the outcome.
Okay, let's unpack this then. Imagine you're the first person to encounter someone in cardiac arrest, whether you're, a medical professional or maybe a trained bystander. What are the absolute first non-negotiable actions?
Right. The very first priority, even before touching the patient, is always personal safety. You just have to ensure the environment is safe for you, for the patient. Once that's confirmed, it's about immediately calling for help, activating the emergency response system or the resuscitation team if you're in hospital.
Time is critical.
Time is not just of the essence here. It's probably the most critical variable. Yeah.
So help is on the way. What's next in quickly assessing the patient in those crucial initial seconds? How do you figure out what's going on?
You'd assess responsiveness, usually by shaking the person gently and shouting, "Are you okay?" And simultaneously, you're rapidly checking for breathing and a carotid pulse, that's the pulse in the neck. This assessment has to be incredibly swift. No more than 10 seconds. That's the guideline. If there's no pulse or any signs of life within that brief window, high-quality chest compressions, CPR, must begin immediately. There's really no time to delay for anything else at that point.
Okay, now here's where it gets truly fascinating and dictates the entire course of action, as you said. When a patient goes into cardiac arrest, their heart's electrical activity tells us a critical story, which medical teams quickly classify into two main categories of rhythms. Can you explain these distinct signatures the heart can display?
Absolutely. The moment a defibrillator or ECG monitor is connected, we're looking to classify the rhythm as either shockable or non-shockable. And this isn't just like a label, it's the fork in the road that determines the immediate treatment strategy.
So tell us about the shockable ones first.
Right. The shockable rhythms are ventricular fibrillation, often just called VF, and pulseless ventricular tachycardia, or PVT. Imagine VF as the heart's electrical system completely short-circuiting. It's just chaotic, irregular electrical activity. It looks like a bag of worms on the monitor. It's not effectively pumping blood at all.
Just quivering.
Exactly. And PVT, on the other hand, shows rapid, wide electrical complexes on the monitor. So it looks somewhat organized electrically, but there's no actual pulse. The pump isn't working despite the electrical signal. And the data shows VF, or PVT, is the initial monitored rhythm in roughly 25% of cardiac arrests. The critical insight here is that for these rhythms, the primary and most effective treatment is defibrillation, an electrical shock to try and reset that chaotic electrical system.
Got it. Shockable means VF or PVT, and the answer is usually a shock. Yep. What about the non-shockable rhythms then? What do they tell us?
Okay, those are pulseless electrical activity, PEA, and asystole. In PEA, you actually see organized electrical activity on the ECG monitor. It might look like a normal rhythm, or maybe slow, but it looks like the heart should be beating. But there's no mechanical contraction, no palpable pulse.
So the electricity is there, but nothing's happening mechanically.
Precisely. The signal's firing, but the muscle isn't responding effectively. Asystole, by contrast, is the complete absence of any cardiac electrical activity. It's a literal flat line on the ECG, and it's really crucial to confirm asystole in at least 2 different ECG leads. You want to rule out equipment malfunction, or sometimes a very subtle chaotic wiggle called fine VF, which can look almost flat but is actually shockable.
Oh, interesting distinction.
Yeah, and the key insight for both PEA and asystole is that delivering an electrical shock won't help them. Survival is, frankly, unlikely unless a specific reversible underlying cause can be identified and rapidly treated.
So that rhythm check really is the ultimate diagnostic moment in those first seconds. It dictates whether you're reaching for the defibrillator paddles or immediately starting to think, what else could be causing this?
Exactly right. It guides our entire decision-making algorithm. But And this is important. Regardless of the rhythm, shockable or non-shockable, one fundamental intervention is constant.
Which is?
High-quality cardiopulmonary resuscitation, CPR.
Okay, let's talk about that. High-quality CPR.
Yeah.
You hear about it all the time, but what exactly makes it high quality according to the guidelines? What are the key elements for effective chest compressions?
Right. High-quality CPR is the absolute lifeline while we figure everything else out. For adults, the emphasis is on compressions delivered right in the center of the lower half of the sternum. And the key metrics are rate and depth, a rate of 100 to 120 compressions per minute. Think the beat of staying alive.
Right, the classic mnemonic.
Yep. And a depth of 5 to 6 centimeters, which is about 2 to 2.4 inches. For kids, it's slightly different, about 1/3 the depth of the chest. The insight here isn't just about pushing down, though. It's about how you push. Too shallow, too slow, or crucially, not allowing the chest to fully recoil between compressions. That means you're not effectively pushing blood to the brain and vital organs.
The recoil part seems really important.
It's critical, allows the heart to refill. And minimizing interruptions is key too, less than 10 seconds ideally. Every single compression counts, and quality is paramount. It's also why we emphasize changing the person doing compressions every 2 minutes. It's tiring work.
Definitely. To prevent fatigue and keep that quality up. And how do ventilations, the rescue breaths, fit into this rhythm?
Good question. If there's no advanced airway like an endotracheal tube or supraglottic airway in place, the ratio is straightforward. 30 compressions followed by 2 ventilations. 30 to 2. However, once an advanced airway is secure, things change. Compressions become continuous, no pausing for breaths, and ventilations are given asynchronously, meaning not timed with compressions. Just one breath every 5 to 6 seconds.
So about 10 to 12 breaths per minute.
Exactly. You want to see visible chest rise with an inspiratory time of about 1 second. But a critical detail we constantly reinforce is avoid hyperventilation.
Why is that bad? Seems like more oxygen would be better.
You'd think so, but giving too many breaths or too forcefully can actually increase the pressure inside the chest. That reduces blood flow back to the heart, which then decreases cardiac output, the amount of blood the heart pumps out. So it's counterproductive.
Ah, okay. So controlled, steady breaths are key.
Precisely.
All right, so with high-quality CPR buying us precious time, the next step, especially for those chaotic, shockable rhythms, how do we actually restart the heart? That's where defibrillation comes in. What exactly is happening when we deliver that shock?
Defibrillation is essentially delivering a controlled electrical current across the heart muscle. The aim is to disrupt those chaotic rhythms like VF or PVT, depolarize a critical mass of the heart muscle simultaneously. It basically stuns the heart, stops the chaos, and allows the heart's natural pacemakers to hopefully take over again and resume a coordinated, effective rhythm.
Like a hard reset.
Exactly like a hard reset. The pads are typically placed one below the right clavicle, the collarbone, and the other in the left mid-axillary line, sort of under the armpit, to ensure the electrical current optimally crosses the heart muscle, the ventricles.
And the energy levels for that shock. Is it always the same jolt?
It varies, depends on the type of defibrillator. For biphasic defibrillators, which are pretty much standard now, the initial shock is usually manufacturer recommended, often between 120 to 200 joules, or J. Subsequent shocks, if needed, are often the same or sometimes escalated to higher energy levels, again, following the manufacturer's guidance.
And the older ones?
If an older monophasic defibrillator is used, it's typically a single higher energy shock of 360 J for all shocks. The procedure itself is very precise, very choreographed. Apply the pads, quickly assess the rhythm on the monitor. If it's shockable, charge the machine. Then, crucially, ensure everyone is clear of the patient. I'm clear, you're clear, everybody's clear. Remove any oxygen source near the chest to prevent fire risk.
Wow, we didn't think of that.
Oh yeah, critical step. And then deliver the shock. The absolute golden rule here is to minimize any pauses in CPR. The hands-off time needs to be as short as humanly possible. And critically, after delivering a shock, you immediately resume chest compressions. You don't wait to check for a pulse right away. We give the heart time to respond while keeping blood flowing.
Okay, resume CPR immediately. Got it. And what about AEDs? Automated external defibrillators. We see them everywhere now. Airports, gyms. How do they fit in?
AEDs are fantastic pieces of technology. They're specifically designed for lay rescuers, people without extensive medical training. The instruction is incredibly simple. Turn it on and just follow the clear audio and visual prompts. They literally talk you through it.
So they analyze the rhythm themselves.
Yes. They analyze the heart rhythm, decide if a shock is needed, tell you when to push the button, and guide you through CPR. They bring this life-saving intervention out of the hospital and into the community, making it accessible to almost anyone. They really do save lives.
That's incredible accessibility. Now, beyond the electrical shock, you mentioned medications. What's the protocol for giving drugs during cardiac arrest? Because it seems like another layer of complexity in a very critical situation.
You're absolutely right. It is another layer. First, establishing vascular access is paramount, usually an intravenous IV line in an arm vein. If getting IV access is difficult or taking too long, we can use an intraosseous or IO line that's drilling a needle directly into the bone marrow, usually in the shoulder or shin bone. It provides very rapid access to the circulation.
Wow, IO access. Sounds intense but effective.
It is. And a vital rule, similar to defibrillation, drug administration must never interrupt chest compressions. We give meds during the brief pauses for rhythm checks, or ideally during compressions if possible. Epinephrine is really the cornerstone medication in almost all cardiac arrests. For adults, the dose is 1 milligram IV or IO, repeated every 3 to 5 minutes for as long as the arrest continues.
Then the timing. You mentioned it depends on the rhythm.
Yes. For non-shockable rhythms like PEA or Asystole, where a shock isn't helpful, we give epinephrine as soon as possible after establishing access. But for the shockable rhythms, VF or PBT, defibrillation is the priority. So we typically administer the first dose of epinephrine after the second or third shock has been delivered, depending on local protocols, often aligning with the second shock. We want to give the shocks the best chance first.
Okay, Epi, for nearly everyone. What about other drugs? You mentioned Amiodarone.
Right. For VF or PVT that persists despite initial shocks and epinephrine, we call that refractory VF-PVT. Amiodarone is the primary antiarrhythmic drug we use. It's given as a 300 milligram IV or IO bolus, usually after the third shock. A second dose of 150 milligram might be considered after the fifth shock if the rhythm still persists. Lidocaine is an alternative if amiodarone isn't available, or maybe if it's contraindicated for some reason.
And you mentioned other specific drugs.
Yeah, those are usually for very specific situations, often guided by suspecting one of the reversible causes. For instance, if we strongly suspect the patient has dangerously high potassium levels, hyperkalemia, we might give calcium chloride. If there's severe acidosis, maybe from certain overdoses or prolonged arrest, sodium bicarbonate might be considered, though its routine use is debated. And magnesium sulfate is used specifically for a type of polymorphic VT called torsades de pointe, which has a characteristic twisting look on the ECG. Each drug has a very targeted indication.
So it sounds like there's this constant search for the why behind the arrest, especially with those non-shockable rhythms, PEA and Asystole, where a shock isn't the primary fix. Emergency teams use this framework, right? The H's and T's. What are they and why are they so crucial?
Absolutely. Asking why did this happen is central. Identifying and treating reversible causes is absolutely critical, especially in PEA and Asystole, because if you don't fix the underlying problem, CPR and drugs alone are unlikely to bring the patient back. The H's are a mnemonic for common reversible causes. Hypoxia, not enough oxygen. Hypovolemia, not enough blood volume, maybe from bleeding. Hydrogen ion, that's severe acidosis. Then hypo or hyperkalemia, potassium levels too low or too high, and other metabolic issues like low blood sugar or magnesium. And finally, hypothermia, a core body temperature that's dangerously low.
Okay, those are the H's. Hypoxia, hypovolemia, hydrogen ion, hyperkalemia, metabolic, hypothermia. What about the T's?
The T's represent another set of critical, often treatable causes. Tamponade, specifically cardiac tamponade, where fluid builds up in the sac around the heart, squeezing it. Thrombosis, meaning a clot. Could be a coronary thrombosis causing a massive heart attack, or a pulmonary thrombosis, a large clot in the lungs, a pulmonary embolism. Toxins, drug overdoses, poisons, and tension pneumothorax, where air gets trapped in the chest cavity outside the lung, collapsing the lung and putting pressure on the heart and blood vessels.
And you're actively looking for clues to these during the resuscitation.
Constantly. History from bystanders or paramedics, physical exam findings between CPR cycles, sometimes point-of-care ultrasound. We're always thinking, is there evidence of a collapsed lung? Could this be a PE? Is the patient profoundly hypothermic? Treating these H's and T's is often the only path to survival, particularly for PEA and Asystole.
Okay, so it's CPR, rhythm check, shock if needed, drugs, and always searching for and treating those H's and T's. Let's fast forward. Let's say after all these interventions, we achieve return of spontaneous circulation, or ROSC. That means a pulse and blood pressure return. The immediate crisis of cardiac arrest might be over, but you mentioned the work is far from done. Our research emphasizes this isn't the finish line. What's the goal now? What's the approach for post-resuscitation care?
You're absolutely right. ROSC is just the beginning of the next phase. The immediate goal shifts dramatically. Now it's about optimizing ventilation and circulation to protect the organs, especially the heart and brain, which are very vulnerable after being deprived of oxygen. We also need to preserve their function, manage blood glucose levels, and continue to diagnose and treat the underlying cause of the arrest. We often use the systematic ABCDE approach again: airway, breathing, circulation, disability, neurological status, exposure, checking for injuries, temperature, for a thorough ongoing assessment.
Okay, so focusing on brain and organ protection, how do you manage blood pressure and circulation after ROSC?
Hemodynamically, stability is key. We aim to maintain a systolic blood pressure ideally greater than 90 millimole Hg, or perhaps more accurately, a mean arterial pressure, MAP, greater than 65 millimole Hg. This ensures adequate perfusion to the vital organs. Initial intervention is often giving fluids, maybe 1 to 2 liters of intravenous saline or lactated Ringer's solution, especially if we suspect hypovolemia played a role or if they are visudiated post-arrest. If blood pressure remains low despite fluids, then we start vasopressors. These are medications like epinephrine, norepinephrine, or dopamine given as continuous infusions and carefully titrated to achieve that target blood pressure without causing excessive constriction.
And breathing. How is ventilation managed post-ROSC? You mentioned avoiding hyperventilation during CPR. Does that still apply?
Yes, definitely. We still avoid excessive ventilation. We typically start at a respiratory rate of 10 to 12 breaths per minute if they have an advanced airway. And we carefully titrate the oxygen. We don't just blast them with 100% oxygen indefinitely. The goal is to maintain the oxygen saturation, SpO2, between 94% and 98%. Too much oxygen, hyperoxia, can also be harmful, particularly to the brain. And that quantitative waveform capnography we talked about, it remains incredibly useful after ROSC.
How so?
Well, it continues to confirm the breathing tube placement, but it also helps us adjust the ventilation rate precisely to maintain the end-tidal CO2, the PETCO2, in a normal range, usually 35-45 millimole Hg. This reflects adequate ventilation and circulation. It's a fantastic real-time monitoring tool.
It sounds like a vital sign in itself almost. Beyond blood pressure and breathing, what other critical considerations emerge in this complex post-arrest phase? Feels like a whole new diagnostic and management challenge begins.
It absolutely does. One of the very first things we do after ROSC is get a 12-lead ECG. We need to see if a cardiac event, particularly an ST segment elevation myocardial infarction, a STEMI, a big heart attack, triggered the arrest. If STEMI is identified, the patient often needs to go emergently to the cardiac catheterization lab for percutaneous coronary intervention, PCI, to open up that blocked artery. That's often the definitive treatment.
So identifying that cardiac cause quickly is key. What else?
Neurological protection is huge. For patients who remain comatose after ROSC, especially if the arrest was due to a shockable rhythm like VF or PVT, targeted temperature management, or TTM, is strongly recommended.
That's therapeutic hypothermia, right? Cooling the body.
Exactly. It involves actively cooling the patient's core body temperature down to a target range, usually between 32 and 36 degrees Celsius, for at least 24 hours. There's good evidence this helps protect the brain from reperfusion injury, the damage that can happen when blood flow returns.
Fascinating. Cooling to protect the brain.
Yeah. And of course, we continue to actively search for and treat any remaining reversible causes. Those H's and T's might still be factors. Close attention to neurological care is critical, often involving brain imaging like CT scans and EEG monitoring to check for seizure activity, which is common after arrest. Assessing neurological prognosis is a major part of post-arrest care. And looking longer term, recovery involves formal assessment and support for potential physical, cognitive, and psychosocial issues. Cardiac arrest can have lasting impacts. And finally, something easily overlooked but so important for the responders: debriefing. For everyone involved, from lay rescuers, EMS crews, nurses, doctors, talking through the event afterwards is really beneficial for mental health, well-being, and even improving team performance next time.
What an absolutely incredible deep dive into the complex, incredibly high-stakes world of cardiac arrest management. It's really given us a window into that controlled chaos. We've covered everything from that initial crucial assessment and the vital distinction between shockable and non-shockable rhythms, through the precision needed for high-quality CPR and defibrillation, the specific roles of medications like epinephrine and amiodarone, and that relentless critical hunt for the reversible causes, the H's and T's. And then all the detailed work that continues even after the heart restarts.
Yeah. And if you connect this to the bigger picture, it truly highlights this intricate dance. It's a combination of deep knowledge, incredibly rapid decision-making, technical skill, and seamless teamwork that goes into trying to save a life. It's really a testament to how far medical science has come in understanding and developing protocols for one of medicine's most urgent emergencies. It's not just one action, it's a meticulously choreographed cascade of interventions, each step building on the last.
So the next time you hear about a cardiac arrest, maybe on the news or in a show, you'll know it's so much more than just starting CPR, as vital as that is. There's a whole algorithm, a whole highly skilled team, and a deep understanding of physiology working in concert under immense pressure to give someone the best possible chance at survival and hopefully a meaningful recovery. And for you, our curious learner, maybe something to think about. As medical technology continues its relentless advance, how might things like real-time data analysis, perhaps even artificial intelligence, further refine these already precise cardiac arrest algorithms in the future? What new insights or tools might emerge to push the boundaries and improve patient outcomes even further in the years to come? Lots to consider there. Thanks for diving deep with us today. We'll see you on the next deep dive.